Good evening, everybody, and welcome to today's episode of Marvelous Medicine, the first for the new year. Let me start off by wishing you all a very happy new year, 2026. And the topic for today is exploring new horizons, a clinician's journey into AI and quantitative imaging. The speaker is Dr. Ashok Puri, who is the assistant professor at the University of Nebraska Medical Center at Omaha. Dr. Ashok Puri did his MBBS and diploma and MS ophthalmology from JIPMA Pondicherry, and he has over 35 years of experience in clinical ophthalmology, both medical and surgical. And he decided to change course or add a dimension to his practice. He did an advanced program in digital health and imaging from the Indian Institute of Science, Bangalore. After which he has been working on models for improved AI medical prediction and diagnosis. So, in his own words, he wants to inspire clinicians to learn and understand AI and start utilizing it in our everyday practice rather than just leaving it to the techies. So the other details will come up as he does his talk today. Thank you so much, Ashok, for taking time off during a working day. And I know it's difficult, and like you said, it's a cold morning. You have to get up for us, so thank you so much for joining. So there are two moderators for today's session. One is another ophthalmologist, and the other a radiologist. So Dr. Samuel Viefert is a clinical lead at the hospital where I work in radiology, MGM Adyar. He's also, other than doing training in radiology, he has also done a PhD in AI and machine learning from the Department of Medical Sciences and Technology at the Indian Institute of Technology, Madras. He's also done a fellowship in thoracic and abdominal oncoimaging from Tata Memorial, and a fellowship in cancer imaging from France. He has several publications to his credit. I request everyone other than the speaker to please mute themselves. So he has several publications to his credit, and so he's probably, compared to Ashok and me, he's Gen Next, who's from the beginning of the career itself decided to incorporate AI in practice. And as we all know, radiology is one of the areas in which AI has made rapid strides. The other moderator is Dr. John Davis Kara, who's not new to Marvelous Medicine. He's a glaucoma, cataract, and refractive surgeon at the West End Eye Hospital and Chaitanya Hospital in Kochi. He was previously worked in Ramchandra Medical College. John is also a graduate of JIPMA Pondicherry, and he's done a glaucoma fellowship from Arvind Eye Hospital. He has innovated the foldable fundoscope, the virtual reality perimetry, smartphone ophthalmic imaging, augmented reality. So all in all, he's another person who has blended technology with medicine. So I think we are going to have an extremely informative session, and hope many of us are inspired after today's session to try and learn technology and AI along with whatever specialty we are practicing. Over to you, Ashok.
Well, thank you, Vidya. And I'll just share my screen. Is my screen visible to all?
Yes, sir.
Yeah. So, first of all, good evening, everyone, and a very happy new year. And thank you, Vidya, and thank you, Marvelous Medicine, for giving me an opportunity to speak on something which has become a passion for me. How I wish I was doing my MBBS at this stage. I would have definitely entered into AI right from the beginning itself. But then I'm on the other end of my career, and this has become my retirement planning, in fact. And I'm really enjoying the whole thing. So thank you, Dr. John and Dr. Samuel, for being the moderators of this session. My links to Pondicherry are not just limited to JIPMA. In fact, I was 4 years old when I went to Pondicherry, and I lived there for 25 years. It was 1964 when my parents shifted to Pondicherry. And that was the time when Gandhi statue did not exist. I mean, it was installed much later. And right at that place, there used to be a wooden pier, and one could walk to quite an extent into the sea. And here you could see the wooden pier. And I remember walking along that, and the Mary Town Hall and the lighthouse. I think these structures are still there. This was my school, the first school I went to, St. Joseph of Cluny High School. Of course, it's a girls' school, but at that time they used to admit boys till fifth standard. And then the Central School right at the edge of JIPMA. I studied there for almost 8 years. And after that, it was JIPMA. And till 1989, I was at JIPMA. And when I joined JIPMA, the rehabilitation and orthopedics block and all did not exist. You could see the, after that, I was in Rajasthan till 20. And now I am in Omaha, the place, the University of Nebraska Medical Center. It's a beautiful center in the Midwest, a very renowned center for so many things, including the Cancer Center, which you can see, the Buffett Cancer Center. And many of you who probably invest in stocks must be taking tips from Warren Buffett, because it's his family and his contributions to this place. And believe me, he lives a few blocks away from the place where I'm presenting. So coming to the agenda of the meeting, I'll keep it simple so that everybody understands. And I really would like people to understand the concepts and then try to come on to artificial intelligence. It's a very important area that we must go on to. We have to learn technology ourselves. Otherwise, we'll be overshadowed by the technology people, like what happened with EMRs. I mean, a lot of physician burnout. So these things have to be developed in the way we want. And clinical experience is very much required for that. So the first part is just a little about artificial intelligence, the changing clinical landscape that inspired me to take AI, the basic facts about AI which one should know, and why should clinicians learn AI. So this is a very small part. The main part is going to be quantitative imaging, the core problem, the existing methods. And after going deep into the mathematics and programming of AI, how I developed a novel deep radiomics-based quantification of disease, which is being applied to not only ophthalmology, but other areas of medicine also, which I'll show you. So the novel method that I'll be describing, of course, briefly, is patent pending. And this talk will mainly focus on computer vision. Now, the landscape in medicine has changed over a long period of time. I entered ophthalmology in 1984, and that was the era of manual surgery and skilled surgeons. You know, people used to say, oh, that surgeon, that doctor, his surgical hand is very good. You know, and that was the monopoly that one had. And I really enjoyed that part. And that was one of the reasons why I took medicine and ophthalmology. In 1990s came machine-based surgeries. In ophthalmology, it was phacoemulsification and the non-stitch surgery for cataract. And I quickly jumped onto it, and I pioneered phacoemulsification in the state of Rajasthan, India, in 1992-93. So, but that was the time when the machines were a little crude. I mean, it was difficult to use them. You had to be very vigilant, very careful. So a lot of people were not converting onto phacoemulsification. So by the year 2000 came the skilled machines. By skilled machines, what I mean is that very high-end phacoemulsifiers came, which had good microfluidics, and because of which a lot of complications, which were dreaded complications of phacoemulsification, like posterior capsule rupture and nucleus drop, all these things came down. And I started using the high-end phaco in 2000 itself. And I found that I could do double the number of surgeries in the same time without getting tired. So I realized, yes, these kind of machines, when they are there to help you, they reduce your cognitive load. But the other side was that the surgical skills of the doctors were being transferred to the machines. So after this, the machines kept on changing a little, but then by the year 2010, people started talking of artificial intelligence and thinking machines. So I started wondering, wow, if the surgical skills are gone, what about my mental skills? I mean, I may be very good at diagnosing certain things, but are the machines going to do it? So I started looking into artificial intelligence, and then I got inspired by my daughter, who was doing her computer science and artificial intelligence in the US at that time. And in 2019, I made my entry into artificial intelligence. So this I started in a very simple way by doing some courses, by understanding the mathematics and all those things. But then when COVID came, that was the time when I had all the time in the world to do whatever I wanted. There was no practice at that time. So my busy practice was not a deterrent or a hindrance to my doing anything. So that is the time when I joined the Indian Institute of Science for a 9-month course on artificial intelligence, digital health, and imaging and all. And today, what has happened, it has become a passion for me. And now you have intelligent machines, and it's an AI-assisted healthcare environment where we are working hand in hand with AI, or we are going to be working hand in hand with AI. So let's come to the basic facts that we must know about artificial intelligence. Now, artificial intelligence refers to machines which act or think like humans. That's the simplest definition. Now, artificial intelligence as such is a broad term. It includes rule-based systems where you need explicit coding. You have to specify everything. You tell a car to move 100 meters straight, then turn left 100 meters, then turn right 100 meters. Now, if there is some obstacle that is coming, you have to write another rule for it. You have to explicitly code. I'll show you an example of this soon. And then came machine learning. This was a turning point because here what was happening was that you did not have to give the rules, or the explicit coding was not required. You just give the data, but then you had to decide which features or what data you're going to give to the machines so that they learn. And they learn so well that they become better and better with more and more training. And but then, of course, explicit coding was not required. Soon after that came deep learning, where all the work on medical imaging, imaging as such, in the world changed. Now, deep learning is a subset of machine learning. It uses an architecture called the neural networks, which is inspired by the human brain. And here, again, there was no explicit coding, but you didn't have to specify the features. All you do is to give images, give data, whatever you want, and the model automatically understands what it has to take. It chooses the features on its own and then comes out with the output or does the task that you want it to do. Now, there are so many subsets or examples of deep learning, computer vision, that is the focus of our talk, natural language processing, speech and audio processing, and generative AI. We talk so much about generative AI because of ChatGPT models which generate text, and there are image generating models also. There's so much of talk, and this is the time when a lot of work on generative AI is being done. Now, the term generative AI, that means there has to be something else also, and that other term is discriminative AI. So generative AI generates data or text like ChatGPT or images, but then a discriminative AI does not generate data, but it differentiates between different data. It differentiates between images, benign, malignant, mild, moderate, severe, and that is the computer vision. So computer vision is discriminative AI, which uses a conditional probability. If you go into the mathematics, it's a conditional probability, and generative AI is a joint probability. So that's the core mathematics behind these artificial intelligence models. So here, I just wanted to show you what a rule-based AI is. If an object comes within the range of the sensor, the door opens. Now, it doesn't know which object it has to open to or not. But then the rule is that this is the object that has come in the sensor area, so you have to open. Now, compared to that, when you have deep learning, you have facial recognition. Now, if the face is recognized by the system, it opens the door. If it is not, doesn't open the door. And what we talk today about artificial intelligence, or we refer to artificial intelligence, is deep learning and machine learning. We don't generally talk about rule-based AI. Now, coming to why should clinicians learn artificial intelligence? Because AI is everywhere in healthcare now. we must understand AI so that we know the capabilities and limitations. Since we are going to use it, it should be an informed use. Like you have an informed consent, so you have an informed usage of AI. You have to collaborate with AI developers. That is so important so that you know about artificial intelligence. In fact, the deeper you know, the better it is, so that you can say how the models are going to be developed. Otherwise, it's going to be something like EMRs. I mean, they're going to be thrust on you, and it's going to be difficult, and that's going to lead to burnout. Because in the end, what happens is it's the clinician who's responsible. Today, we talked so much about chat GPT is going, these language models. They will be entering all your voice data, whatever you talk to the patient and what the patient tells you, everything gets entered into the EMR. But then no company takes a responsibility. Finally, it's a doctor who is responsible. So you've got to do double the work. So there has to be some way that we know that our workload does not increase. Then clinical experience matters. That is where the technology people lag behind. Some of them say that, okay, we'll read medicine, we'll read the subject and then go on and develop models. No, it doesn't work. There was one gentleman who told me, just teach me something about retinal OCT images, optical coherence tomography images, and then I'd start working on them and build models. I said, no, it's not as simple as that. There is a lot of clinical experience that is important, and we'll come to that soon. And the other reason is that we have to avoid the tech first mistake. It's the clinical first that has to come. What I mean by this is that, for example, in a case, a patient with a patient's retinal fundus image, if you take that, there are lesions which are present near the fovea or the macula, which can impair vision. And there are lesions present at the periphery. The same lesions might be there a little at the periphery, which doesn't hamper the vision. So technology first means you have to be accurate for all. And if you miss one or two very small lesions right in the center of the fovea, it doesn't matter to them because they are only comparing the area. But in clinical first, what happens is that if you miss a lesion, a tiny lesion right at the fovea or the macula, the center of the retina, which is so important to see, your model must be penalized much more than missing the same lesion which is at the periphery. So the clinical first part will never come to the technology people. And if they want to learn medicine and then come, they need not only to do the courses, but they have to even sit and practice medicine for at least 5 years or so, or 10 years, so that they understand what is clinically relevant and then build models that way. And of course, we need to know AI so that we avoid errors in adapting AI to medicine. I mean, you see models which are made to, say, detect cars, animals, and then you adapt them to to medical diseases. No, it doesn't work because at times you are comparing apples to oranges. And let me show you an example of this, or two examples of this. Now, these are images from an ImageNet database. Now, this has been used to create so many computer vision models for classification and lots of other things. Now, when these models came, immediately the technology people and some of the doctors who did not understand this well jumped onto it, and they came up building models that would detect retinopathy. Diabetic retinopathy. So it can detect normal or classify normal, mild, moderate, severe, and proliferative retinopathy. But if you see, the difference between the fundus images is very small. There are small features which are changing, but in the ImageNet database, the objects are totally different. So what was actually required was to compare apples with apples. So what you needed was to develop models which can tell you, okay, this is a chest X-ray, this is a pelvic X-ray, this is a skull X-ray, this is a foot X-ray, and this is a hand X-ray. So something like that was required. And so what was needed for these models of retina was not just the ImageNet database, because there were small subtle changes. Small subtle changes would come from a model which differentiates breeds of cats, breeds of dogs. So they're all practically the same, but then there are small changes in features. Now, these models were the ones that could be really translated to these images, and we have realized it the hard way. And Again, example of segmentation errors. Because why segmentation is? Because when we say AI is being used a lot in medical imaging, so the most common use of AI is segmentation. What is it doing? It's marking out or segmenting an object. It colors an object or shades an object so that you can identify it or locate it and all sorts of things. So this came from such models where you were masking or creating masks for cars, for pedestrians, for roads, for pavements. So all these models were then translated to using transfer learning, they were brought on to medical images. Now, one place was the problem that came was that these models had objects with very well-defined boundaries. Now, in medical images, the boundaries are ill-defined. So how do you make the ground truth? Because when you want to train the models, you have to specify what is the ground truth and what the model learns, because you're giving the model the original image and a masked image. And the model then gradually learns how to create a mask for a given image. So now when ill-defined boundaries are there, so it was very difficult to say what is what. I mean, where should you put the boundary? The same way in retinal fundus, you have a very tiny lesion. And this tiny lesion is always missed because most of the algorithms today, which are doing segmentation, they miss these small lesions because the inherent nature or the architecture of the model is such that they're downsampling the image. There's a loss of data that is taking place, and you can't afford to do that. So these are what the problems that occur. So therefore, what I always feel is that the clinicians should learn AI, you should learn the mathematics, learn programming, build models if you really want to go deep into it to develop AI for us or for medicine or for the doctors. So, and the best way is always do it yourself. So you should know how to do it. And that's why you'll find that you will live in, enjoy all this. Now let's come to the main part, that is quantitative imaging. Now, from images, we can quantify a lot of objects or features. So that is referred to as quantitative imaging. Maybe a disease or a biomarker can be quantified. And why do you need quantification? What are the methods for quantification? And a novel method, which I have developed, we'll just show you that. So what is the need for quantification? This quantification always gives an objective metric. A doctor may feel, okay, this is a lesion. Now it looks as though it has increased after these many days. Now, what were the factors or what are the features that the doctor saw? If you can quantify it, you can make it better. And that's exactly what quantitative imaging does. So you can estimate the disease severity when the patient comes. You can track the progression of the disease, plan the treatment very objectively, monitor the treatment response, and you can have the endpoints of treatment or endpoints of even clinical trials very specific. You can detect recurrence and, of course, early detection. And the most important is that you can substantiate your decisions. You may require this for the patient, for the payers or the insurance companies, or even for legal problems when you land up into. So what are the methods that we have for quantification, or how AI is used for quantification? There are various methods. One is classification, just like how we were classifying things as mild, moderate, severe. And there was no way in which we could grade what was mild and what was moderate and what was severe, because there was a big spectrum in that. The nuances were never coming out, but then these were classification models. So they were quantifying things, but then they could not follow up very well. The second came with the image comparisons. There's so many methods by which you have standard set of images and you compare those images with a diseased image that has come, or you take some diseased images and compare them with a given image from a patient. So these are these atlas-based methods, Siamese networks, and all sorts of things which are there. But then they have been successful, but they have not been applied or implemented well in medicine. Segmentation. We've already talked a little about it. Now, segmentation is something which is the most common in quantitative imaging. And what is coming is radiomics, which we'll talk about soon. Now, an image is worth 1,000 words. So an image can be described very well. Now, describing an image, I think, goes back to when we just entered school. I remember a time when you're given an image of a cow and you're told to describe the cow. So what we would do, describe the cow, say it has heads and horns and legs and tails and all sorts of things. Now, what were we actually doing? We were doing something called feature extraction. We were extracting all the features. So these are the features in the images which you extract, and you would like to quantify each one of them so that you could use it for different purposes. Now, let's go on to something which is closer to medicine. This is an image of an aging face, the same person, but then at different ages. So if you want to quantify various features, you could pick up each one of them and then quantify them. So let's take just one feature, and that is the nose. Now, how can we quantify what is happening in the nose? The most commonest method is segmentation, where you are outlining the nose. And once you create an outline using a model, in fact, it creates a mask of the nose, and then you can tell the model, okay, remove all the pixels of the mask and keep only the peripheral ones there, one or two layers of, or one or two pixels at the periphery, and then you get an outline like this. So with this, what you can do, you can get the length, you can get the width, you can calculate the area. And if it's a scan where you got multiple slices, you could calculate the volume. Or if it's a 3D model that you've made, again, you could calculate the volume. So, but then there are disadvantages of this. Now, the biggest disadvantage is the boundary errors. Like I'd shown, the boundaries of a car are very easy because they are sharp. The boundaries of medical lesions are not easy to draw and therefore train the models. So you have boundary errors. So, and because the measurements are in pixels, it all depends on the resolution of the image, because you're converting pixels into millimeters or microns. Now, how many millimeters is one micron? I mean, how many millimeters is one pixel, or how many microns is one pixel? That is the resolution. And this is prone to errors. And how much error it leads to, I'll show you soon. And the second part is you get the outer dimensions, but the internal pattern is not known to you. And even before the outer dimensions change, there are a lot of changes that occur in the internal dimensions, within the dimensions, the internal features. Now, segmentation errors are not that much of a problem in larger measurements. Say, for example, in a brain MRI, if the caudate nucleus is, the volume is calculated as 7,100 cubic millimeters. Now, if you have an error of one voxel, because these are 3D images, a pixel is a 2D structure, a 2D square, and a voxel becomes the same pixel in 3 dimensions, that it has a depth also, so it becomes a cube. So if you have an error of one voxel, it's just about 8 millimeters cubed, and 2 voxels are 64 millimeters cubed. And therefore, the overall error is 1% or even less than 1%. But what happens is when the size of the lesion keeps reducing, the percentage of error increases. I'll show you this in retinal OCT images or retinal optical coherence tomography images. So here what is happening is that somebody has segmented out or a model has segmented out the fluid filled area. Now, the resolution of a retinal OCT is 3 to 4 microns in the axial direction, the vertical direction, and 1 pixel is equal to 11 to 12 microns in the commonly used OCT machines today, is 11 to 12 microns. So now in the first image, what is actually happening, if you enlarge and see, you are having the boundary which has been fairly well demarcated. But in the second image, you can see below that there are a lot of errors in the pixels which are there. So how significant is this error? So when you go on to retinal thickness measurements, because everything is in microns, the normal thickness is somewhere below 300 microns. And if you have say, an error of 3 pixels in a case with macular edema where the retina is swollen, so keeping the axial resolution at 3.9 microns, the axial error is going to be 11.7 microns per edge, the top edge and the bottom edge. So the total error goes to 23 microns or more. And the same way, when you go to the transverse resolution, because the resolution is about 12 to 14 microns, 1 pixel is 12 to 14 microns, the error in transverse direction is 36 to 42 microns per edge. And therefore, it's about 72 to 84 microns that the error can occur. Now, what happens when it goes to the volume? And that is where it becomes larger. So a volume lesion of 300 ml, because what we talked today, or what the machines have started giving the doctors today is, okay, this is the segmented area of the fluid-filled cyst. So you can calculate the volume of fluid that is accumulated there. So say 300 microliters of fluid is there, but then you could have an error of almost 30% more or even 30% less. And if the fluid comes down, because we always look for the fluid reducing, the error becomes more. So these things have not really worked practically. So that's the biggest problem of these segmentation errors which occur. Now, coming to the internal texture, because segmentation gives you the outer boundaries and dimensions, but doesn't tell you about what is inside. And what is inside is important. So let's now before we go further, I just would like to tell you that a digital image is a grid of pixels. Now, each pixel has a value. Say, for example, you have an image A. Now, this is how the image would look in the pixel form. And if you want the values, then it is this. 0 means black, 255 means it's pure white. And then you have all shades of gray in the middle. So let's go back to the image of the nose. So this was the area that we were segmenting out. But now what happens is we want to go into the details. Let's see the values of pixels. Maybe that gives us some insights. So what is done is that you go and segment out one area. Say, suppose we segment out the area of the nasal crease. Now, these pixels are highlighted in the main image, and you could see that the intensity, the color varies. That means the intensity varies, or the values of the pixels are different. The lighter ones are higher values, the darker ones are of lower values. So now these pixels are not visible to the human eye. So you can get values which are so much in detail, but you have to segment out the area from where you want the value. Now take an old nose, a nose of an older patient, and the same thing is done. You can see the difference in the color or intensities. So now you have on the left side pixels from a young nose, and on the right you have pixels from an older nose. So now what one can do is to compare the pixels or get the relations between pixels so that you get the information of the texture, the pattern, and so many other things. Now, say for example, you take one pixel, say X, on both the images, and then you move in the horizontal direction to the right and see which two pixels are of the same intensity, or if this pixel is of so much of an intensity, what happens to the neighbors. So lots of relationship between pixels can be got. So that's how you quantify the texture and the pattern which is there. The same thing is done in another direction also. Now, when you have features like this is what is being done in radiomics. Omics, because there is huge amount of data which is there. One image would have millions and millions of pixels, and each pixel is a data. So you have got a huge data that is there, and you actually analyze the whole thing and then come out with features of different kinds. The changes in energy, changes changes like GLCM and all. There's so many features which are there, about 800 to 900 or even more features that can be extracted from these images. Now, when you extract features and label them, and you select them actually, or you don't take all the 900 features, you just select the important features and label them. That becomes a radiomic signature. So with this, what happens is I get a radiomic signature of a young nose, a segmented area that I define, and I get the radiomic signature of an old nose. Now, when I take these features, train a machine learning model, I'm able to do a lot of things. I can have a regression model, I can have a classification model, and so many things. So that's how you can sit and quantify images based on radiomic signatures. So this is what is being actively researched in medicine today. So radiomics, which is also OCT omics, for retinal OCT or optical coherence tomography images, I'd like to just show you the pipeline. You have an OCT image, segment out the region of interest. So it's difficult to segment out. People have taken the whole OCT itself, and that becomes a problem because the computations are plenty, and you need very high-end models to, or very high-end computers to do it, or supercomputers at times. And then use a library that, I mean, there are many of them, but then the most common is pyradiomics. Use that and extract so many features, those 800, 900 features, and then select the features, label them, and give it to a machine learning model and come out with outputs. Now, the radiology people have gone a little further. In fact, they came out with radiomics, and the image was acquired. And after acquiring, you have segmentation, then you get the region of interest, and then do a 3D rendering so that you have a three-dimensional representation, and you can take slices from there and then get the radiomic signature, like I've told you. So with these radiomic features, you can add other features also. That means you can add genomic features, you can add clinical features. It's all concatenations. You know, when you convert anything into a vector, all the vectors are same. They may be coming from an image, they may be coming from clinical data, they may be coming from genomic data. You have to just concatenate them and then build models. So this is the way medicine is progressing, and this is where exactly things are going on. And a lot of research is being done. We'll have good outcomes in future, and it's going to change the way we are practicing medicine. So, but radiomics again has its own drawbacks, because radiomics requires segmentation. You have to segment out the area, and that is where the biggest problem comes, because it may not be the same. Especially in disease states, these areas might change. Especially if you use AI, it may not give you the same outline. And even manually, it's sometimes a little difficult to get the exact outline in longitudinal measurements. And then it excludes the surrounding zone of spread. Now, when you have a tumor, say, I'll just give you an example of a skin tumor. You want to remove it. You go at least, say, 5 millimeters of a few millimeters beyond the edge that is visible, because you know that there is an invisible spread which is taking place. Now, when you segment out the region, you are only taking the region what is visible to you. So your segment, you just don't know how much you're missing. So that's a big problem that occurs. And then it's a complex procedure, because you have thousands of features, and from there you're selecting out the most important ones, you're labeling them, and using machine learning models, which are, of course, not as capable as the deep learning models. And you're getting insights and predictions. And there are always irrelevant features which may be taken, and there's a lot of noise in the image, grains, and so many things which may not be representing the feature that you want. So all those drawbacks are there. So therefore, the results are coming, and people are trying to make it better and better by knowing all the drawbacks which are there. Now, let's come to deep learning. So when you have machine learning and you have a better method using deep learning, which can extract features for you. Now, deep learning extracts features. I'd like to show you what it actually does. So you have an image, there is a kernel of deep learning in every layer, and that slides over the image, extracting the numbers. Extracting features means you're extracting the numbers. And after the features are extracted, they pass through different layers, and finally you get the output. So there are so many numbers that you have within the deep learning model. And instead of you giving the features, the deep learning model knows what features to extract, because it has been trained so well. So if you want to extract features of edema, it knows what features of edema that you have to extract. If you want to extract features of a tumor, it knows exactly what features it has to extract. If it's a good trained model, yes, it does know. So why can't we use those features? So this is what the thought that came to my mind. Then let's work with the features of deep learning itself. Now, to just show you what actually happens in deep learning, once it extracts the numbers, there's a lot of combination that is done. The initial layers of the deep learning model will extract edges and edges pass through different layers. They're all joined together, combined together to form parts of an object, and then even the whole object. So all those things are done. So this is all done in a high dimensional space. So now, when all the finally, when the model predicts certain things or comes to a conclusion, these features, what all it has extracted are separated out in such a way that you could have a decision boundary or a boundary between them, so that when you give a new image, the model immediately knows where exactly it falls in the feature space, and it tells you, okay, this is this particular disease. So like, for example, in retinal OCT images, the model in a very high dimensional space separates the choroidal neovascularization, the drusen and macular edema features. So I thought, why not work with in the feature space and get measurements from the feature space itself rather than working with the pixels. And that is how I developed this direct deep radiomics approach. Now, radiomics is what I've told you. Deep radiomics is when the radiomic-like features are extracted from the images by a deep learning model. And direct deep radiomics is that we are not using any human crafted features or handcrafted features and putting them into a deep learning model. We are making the model extract the features and using the features directly to take measurements. Now, I'll just show you my model, but then it's based on macular edema, how you quantify it. So I thought I could just tell you a little about macular edema, the commonest cause of blindness in the working age group and in people over 65 years of age because of retinal vein occlusion and, of course, associated with macular degeneration. So the vision is very good initially, and this is what happens to the vision when a patient develops macular edema. There's no cure, there's only control with anti-VEGF drugs or vascular endothelial growth factor suppressants. And not suppressants, I mean, it's agonists, no, antagonists. The retinal optical coherence tomography machine, which takes a retinal scan, which is just like an optical biopsy. It shows you all the layers of the retina. So what is macular edema? It's the swelling of the retina. So this is, of course, not the retina, but this tells you what actually happens. A leaking pipe in the wall, and there's water logging that is taking place, or seepage of water. And in the retina, what happens is that there are leaking blood vessels, and there is fluid that is escaping into the retinal tissue. So normal retinal image, OCT image is there on the top, and this is how it looks in macular edema. So both these conditions have got fluid in them. Now, the plumber comes and seals a leaking pipe. But then here it's an ophthalmologist or a retina specialist who gives anti-VEGF injections and seals the leaking blood vessels. So now what the plumber does to confirm that the leak has stopped uses something called a moisture meter. It gives a precise numerical value, which was high initially when the waterlogging was there or before the leak was stopped, and it quickly falls down after the leak stops. So he has a precise number, follows that, and that's it. He knows that, yes, the leak has stopped. Now you can do the other repairs of the wall. But then he doesn't look into the thickness of the wall, how much it has swollen, or it doesn't look into how much of fluid has got collected in the wall. No, it doesn't do any scan of the wall. But what do ophthalmologists do? They look at the thickness of the retina, they look at the amount of fluid that is collected by segmentation algorithms and calculate the fluid volume, and then they're trying to tailor the treatment according to it. But that has not really worked. That is because we don't have a moisture meter like metric, which is based on the retinal pattern that can tell you the leak has stopped, or the leak is increasing, or the leak is reducing, all those things. And these have got a lot of implications on the patients. Now, first is there's a delay in diagnosis. The retinal thickness, it may be normal. A small early abnormal pattern, it may go undetected. And the treatment, even if macular edema develops, is not personalized. It's a one-size-fits-all treatment that is given. So all patients are treated alike. That means you're given 3 to 5 fixed dose monthly injections of anti-VEGF drugs. So every month, give injections regardless of what is happening. And this is called, this may lead to over-treatment, or some people may require less, but then you're giving more. And some people require more, but then you're giving less, because everything is fixed. It's a rule-based stuff. And this is called the loading dose. And then you have maintenance doses. That means if the response, that is the thickness reduces, the vision gets better, increase the intervals between injections. After giving these 4 or 5 injections, increase the intervals. So 8 weeks, 10 weeks, and if the response is not satisfactory, reduce the intervals, or if it was satisfactory, increase them. And then when you find that, oh, the edema is recurring, okay, come down with the intervals. Now, but on what do you base this? This is all on semi-quantitative and subjective metrics. Now, this is exactly where we want to quantify things. So segmentation and area, fluid area, volume, these exist, but they are not very good. Therefore, the treatment is not personalized. Radiomics is being researched, but hasn't really come out very well with some algorithm that can tell us. So when I looked into deep learning and I worked on in the feature space, that's the beauty of mathematics. You can do a lot of things. And I came up with an edema score. Now, the normal edema score is at least around 1 or less than that. So here I'll be showing you some images of macular edema, the retinal OCT images given to the model. This is before treatment. That score was 10.12. Now give the image after treatment. 1 month after treatment, the score comes down. Another 2 months after treatment, the score goes down further. And the treatment was discontinued, and then the edema recurred, and the score increases. So this is what we actually need, so that you can tailor the treatment according to what the patient requires, or according to the disease burden which is there, and not a rule-based thing. Like if we are about 30 people sitting here, all of us have macular edema, everybody is given the same loading dose, 4 to 5 injections, one injection every month. So maybe some of us don't require that much, or some may require more. So over-treatment is costly because anti-VEGF drugs are expensive. In the US, it's nothing less than $2,000 to $2,500. And so with such a cost, I mean, one would definitely like to tailor the treatment according to the need. Otherwise, you're giving over-treatment. And now people are talking that if you over-treat, it's something like you've given too many injections, though the response is there, but some of these patients may be landing up with retinal damage, which later on would be affecting the vision. So all sorts of things are coming out. Now, this kind of a score was then applied to certain other domains of medicine. So just adapting to that. And one interesting domain was the mammograms. So the radiologists look into mammograms. They have a different way of grading mammograms and all. But then at times, if there is a cancerous area, suspicious area, they may be looking at it. They may not get a biopsy done, may get a mammogram repeated. But if you can quantify that, it would work out very well. And the second important place was where there are dense breasts, or there is neurofibromatosis and all, where there are a lot of whitish areas which are there in the mammogram, and there are cancer cells hidden here and there or overlapping on that. And the radiologists find it very difficult to detect them. So when this was applied to mammograms, and this study is going on, you could see how the results were. So this is a normal mammogram that was given. The score is near 0. And another normal mammogram that's given, score again near 0. We'll give another normal mammogram and then see what happens. No, sorry, this is a cancerous one, a malignant one. And in these mammograms, you could see that the score has increased. So we have an objective measure that you could follow and easily do a longitudinal follow for patients. Now, as I told you, some cancer cells may be hidden. Now here you could see there's a lot of whitish areas in the breast, but then the score is low. Now I'll show you another image in which there were malignant cells here and there, which would have been difficult for the radiologist to really know, but then the mammogram score here was high. So now this is being applied to so many other domains of medicine also, and domains other than medicine. A lot of the work is going on that. So I'm very happy to be doing this and coming out with newer things. So this is a direct deep learning approach, because you're taking the features and measuring them. You're not measuring directly from the pixels. So it's something like a doctor perceives something, says he gets an intuition. Now this tumor looks to be increasing. What did he see? Maybe if you could do a functional MRI and know how much was the area that was glowing or the neurons were firing, something like that, if you would quantify that. So here, the artificial intelligence models, because of their feature space, give you that kind of a possibility to do, or the facility to do. So now this extracts features directly from deep learning models. There is no segmentation that was done. Just give the image and the model tells you the score. There are no machine learning models involved. Deep learning is much more powerful. It includes visible and the subtle invisible spread into the surrounding. It takes into account everything because there is no segmentation that is done. The area is decided by the model itself, and it's a single metric which is very easy to use because it's a continuous numerical score. So the beauty of AI is that it's all mathematics, and if you have love for mathematics, it's some area that one could really explore and go on to it, whatever stage of medicine you are in your career. And that brings me to the end of the talk. Thank you very much.
Thank you, Ashok. John, would you like to take over?
Thank you, sir. So that was very informative and very nice to see this OCT omics and radiomics approach, because
So,
I'm tired of looking at
1 minute, John.
measuring.
Ashok, your screen is still sharing.
Oh, I've stopped my share.
Yeah, done. Now it's good.
Right. So I'm tired of looking at all the OCT measurements and confused at which part should we measure, how much should we look at, and I'm happy to get a single unified score which would tell us what we are looking at, and that's sort of looking at intuition. So that is very interesting to know. And like you said, in ophthalmology, we are looking at very small micrometer things. We cannot afford to have a lot of errors. We have to we have to make sure that we avoid all the errors as much as possible. So that is very much a priority in ophthalmology specifically. So very interesting, and I'm happy to know a lot of ophthalmologists are there in this AI field, and radiologists as well. So it's there in our blood.
Yeah, and
And,
I think we must go deep into it, Just,
Mm.
when one of my professors at Indian Institute of Science used to say, go deep into it, learn to build models yourself, because otherwise you just remain with concepts which people tell you. You can't
Mhm.
get creative. You can't understand what exactly the technology people are doing. What are they multiplying with what? Because everything is just matrix and vectors and their multiplication, additions, and all sorts of things. It's very interesting. Once you get into it, then you'll find that, oh, it's fantastic.
Right.
And we'll have
And
to break that.
interestingly, yeah, just
Sure.
adding, sir. So interestingly, I made a very easy to make AI model by using teachable machine. So for all of you listening, teachablemachine.withgoogle.com. It's a free platform from Google where you can just put different classes. You can put this particular box. You fill it with images of normal retina. Fill another box full of severe diabetic retinopathy. Something else with subhyaloid hemorrhages. You put all of those different categories and just click a button. It learns by itself and creates a model for you, which you can use anywhere you want. So kids are using it to detect whether a person is wearing a mask or not. Uh, Detect a particular event happening or not. Sort various different colored items or different shapes of items. So all these things can be very easily done by using these
Yeah.
free platforms.
Yeah, and it's nice. The doctors have to go on to it because the ones who are at a disadvantage are the ones who are actually practicing. This no time. You're busy with your clinical work, and you got to know this because the youngsters who are coming, they know it. Now, school kids, if they know all about this, we as doctors didn't know anything about it. Or, of course, once you plan, you decide your retirement. Like I decided, okay, I'm not going to become director of any hospital or something, because a lot of people or the corporate ones were coming there to Jaipur in Rajasthan. I said, no, 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 I don't. I want to do something creative and interesting. I want to sit at the beach. I should think of Pondicherry, sit under the umbrella with a laptop and sip a little vodka, and then come on, keep on doing your coding and other things and build models and enjoy it. So it all depends on that. But yes, we practicing doctors must look into models like what you have mentioned, and it'll be really good.
Dr. Avinash Supe, you have your hand up, sir. Thanks for joining. You wanted to ask something or make a comment, sir?
I think first thing I would like to really commend Dr. Puri. It was really amazing. I mean, the really way you showed machine learning and deep learning and the models you created of edema and scalability into mammography was amazing. I think it only tells
Thank
you
you.
that
Thank you.
technology is learned by a doctor and how much he goes deeper into radiomics and all, how much it really makes a difference to the understanding. My question
Thank
is,
you.
this is all, I mean, perfect. I mean, what you have really done. But if you want to build the clinicians' trust, I think most of these models are still descriptive, right? I mean, you are just describing that this is there. How much is the evidence now is generated for these models into, say, trials, or compare it with the human and say that AI adds to your clinical decision making and it makes a change into the clinical outcomes? I mean, what kind of a research has been done on this, and how where we are? I mean, this is an amazing journey. And then how do we progress further towards improving the clinical outcomes in a trial mode? That's what I wanted to ask.
Yeah. Thank you, Avinash, and thank you for the kind words. And of course, it's a very good question that you've come on to. Now, these, because it's patent pending, I'm not able to show you the details of this. We are discussing with a lot of companies which make these OCT machines, and they're quite interested in it. So all that is going on. The clinical trials are on, but then I have worked a lot with longitudinal data, the Olives data set, the Duke University data set, and all. And it shows that it is something, a metric that can be followed better than what retinal thickness tells us. Because as ophthalmologists would know, that what is retinal thickness is actually the central subfield thickness. It's the central 1 millimeter zone of the macula, and an average thickness of that is used. Now, you can have edema which is extending beyond the central zone. So, retinal thickness is definitely not a true reflection of the edema that is existing in a patient. So, how can you decide the treatment based on this? So that's why you have one size fits all treatment, a blanket treatment, a rule based treatment that goes on. So the second thing is that these models are explainable. Now, when I say that, okay, the score is 10.5, I have a method by which you can easily visualize exactly which are the pixels that the model chose to give this, to get to this particular number. So that is there. So I've not shown that purposely, but then yes, they are explainable. It's not that it's looking at some other area and then telling you, okay, this is the score. You know exactly what area it is seeing. So the trials are showing they are very promising. Yes, the prospective clinical trial has not been done because it's all observational studies and retrospective trials which are going on. As the time goes by, we'll get into the prospective trials also. And the radiology department here is looking into getting onto mammograms. So, in the US, you have a lot of problem with IRB and so many things, institutional review board and data, collecting data. So that's the tough part which is there. I mean, so I'm just navigating through that so that we are able to get onto the actual clinical trials there also. So it takes a little more time here. Maybe if I was in India, it would have been much
No, no,
easier
in India,
to get
actually,
data.
I heard somebody once, I think a talk, the trial was going on about Niramaya, I think and they were trying to do about the mammography and AI, and they were trying to show how AI enhances the human kind of an decision making by few percentage. But I think I feel such kind of trials are coming, or such kind of studies are coming, which will definitely enhance the trust of the clinicians, and we'll start using it for a better and finer kind of a clinical decisions. I think that's what I think. Fantastic work. I really again
Yeah.
appreciate and
But
enjoyed the talk fully actually.
Thank you. Thank you. And the important part here is that we don't want AI to do things what doctors can do, what doctors cannot do. We can't analyze pixels. So if it can quantify things, it substantiates things, and you are at in a better position to give the treatment or substantiate the reasons why you have given this particular treatment. It becomes very important for us to make things very objective.
So
Thank
wouldn't
you.
the scan quality, the noise create a lot of problem in OCT omics, radiomics?
Yes, in radiomics, yes. But then when you're using deep learning, when the trained deep learning models are there, they know how to get rid of the noise or filter the noise to quite an extent. So that's why these models are robust. We've tested these the OCT models on different machines, data from images from different machines, and they're almost the same. There's a very
So
small
you're
difference.
saying it is machine agnostic. You can actually
Yes,
go from.
it
Oh,
is machine agnostic. Yes.
okay. That's wonderful to know. That's awesome.
We have Dr. Avnish Khare, whom Puneet calls AI evangelist. So, would you like to add something, Dr. Avnish Khare?
Yeah, thank you, madam, for giving the opportunity, and thank you again to Puneet sir for inviting me. Ashok sir, I really enjoyed your talk, and I'm also doing work in the field of enhancing AI literacy for medical professionals. And you reminded me of my days of doing that course on Udacity where I learned about linear algebra and all those multiplications, building a deep learning model. So thank you so much, and very nicely presented, very crisp. I like the slides. This is how the slides should
Thank you.
exactly be from an educator, and also you explained very well. And thank you so much. I enjoyed it a lot, and I
Thank you.
learned a lot as an educator to educate other medical professionals, how to give examples and how to show them how to learn. So this was my comment for you, and I would like to connect
Thank
with you
you.
on LinkedIn post this webinar, if you would allow. I'll send the request.
Well, LinkedIn, I hardly see, but yes, my UNMC mail is there.
Sure.
If you
So
don't mind, Ashok, can you just post whichever email you're comfortable sharing? Can you just type it on the chat box? Because I'm recording, so I'm unable to kind of minimize and take your email from elsewhere. So we have our other moderator. We had two ophthalmologists going at this AI. So we'd like to bring in Dr. Sam Reifert now. Sam, your comments and any questions to Dr. Ashok Puri.
Yes, very good presentation, sir. So I am also
Yeah.
working in AI. What you said is correct. We have gone beyond segmentations. So we have gone into radiomics. So through radiomics, there are some models where I have worked on. I can pinpoint and precisely say this is HPV positive, especially in head and neck cancers, a nodal spread. So I can say without even testing through blood. So those kind of radiomics features. So like we could extract some 300 features on the lymph node morphology. We have the heat maps, heat sensing maps like this with some 7 8 features. So I always tell my residents also that radiology is evolving so much so that probably one day we'll first do the coding part. Like the deep learning projects will come in as a mandatory curriculum. Of course, like you said, we need to supervise the machine. Machine will not be correct. We are not at that stage where the machine is, precisely giving us the data. So we need to know our anatomy or basics very well, and then we can correct the machines. So a very good presentation, yes, and very happy to listen to you.
Thank you.
Thank you, Sam. We have Anand Pangarkar, old acquaintance of Dr. Ashok Puri. Anand, would you like to say something?
Yeah, Ashok, nice to
Hi,
hear.
how are you?
Nice
Anand
to
will
hear.
probably like Ashok would probably like to see you.
Oh, my.
Dr. Bangarkar was my senior by I think 2 or 3 years when
Hello.
I joined my master's in ophthalmology at JIPMER. Oh,
Very- Can you hear me?
Yeah.
Yeah.
Am I on?
Yes.
Yes.
First of all, you said that as we try to magnify the things, the error goes on multiplying in as regards the measurements. So that is what we call in your technical parlance noise. In order to attain specificity, will this noise interfere? One thing. Second thing, so far AI is being used for two different things in ophthalmology in India. One is for teleophthalmology, and second one is the so-called AI software available to tell ophthalmologist whether the patient has indeed really has glaucoma or has diabetic macular edema. What I am trying to find out is, will this be able to beat an ophthalmologist by detecting some missed things, one thing, and second, will it
I think we've lost Dr. Pangarkar.
Dr. Pangarkar, you got muted. You got muted, sir. Please unmute yourself. Dr. Pangarkar, please unmute yourself.
I think his first question was whether these algorithms can beat an ophthalmologist in diagnosis.
Yeah, I mean,
No, that's not the
well,
point. That
yeah.
is one thing. Can he supplement one thing? Second thing is, can is it will it be able to predict that? See, both these examples, three examples we will take: a patient of glaucoma, a patient of neovascular age-related macular degeneration, and third is diabetic macular edema. Whether it would be possible for us to predict based on AI that this patient will have this vision, or will, if this loss continues like this, he will have no use for vision in 2 years, 5 years, 10 years.
See, as the models get more and more precise, they give you more and more data, then one should be able to do it. I'll give you an example. Actually, I would like to go to the first thing that which you mentioned, that the errors increase as you zoom. No, it's not like that. As you use models or develop segmentation models for images which are looking at lesions in microns, the errors are much more.
Yeah.
The smaller the lesion, greater the error. So that is the big problem. So then how can you do longitudinal follow-ups? So those are the problems with segmentation, the errors. 1 pixel error in a big, in a large, say 7-8 millimeters lesion is not going to be much. But then 1 pixel in retinal OCT image is going to give a greater error, especially in volume. So now what I have been developing is AI for enhancing what the doctors are doing. I mean, if I say that this macular edema score has increased, yes, you also see that this edema has looks to have increased. The retinal thickness has gone up. So this is, you're not measuring, but you're seeing that. But using that itself, can you quantify it? No. But what we want to do with radiomics and these kind of methods or deep radiomics is that you quantify it. So if you have a normal thickness and with that there's a slight change in pattern, the score may be 1.5 or 2. If you have a massive edema, it may be 10 or even more. So if you can quantify it, it enhances the doctor's decision-making process. And now today you have a patient whom you give an anti-VEGF injection and the score drops from 10 to maybe 8 after 1 month, and then it comes down to 4 after 2 months. That is after the second injection that is given. So you not only know the score that is coming, but you can calculate the rate of fall. See, if a patient has been given an injection and the score only drops from 10 to 9.5, you know that the response is not there. So are you going to wait for 3 months before you change the drug? No, based on the response, maybe once the clinical trials come out, you could change the drug in the very next month itself. So those are the kind of things. And if a patient score falls from 10 to say 3 in the very first month, why do you give the
It is
second
known as
injection?
measurable and
Delay it.
measurable and quantifiable thing instead of descriptive.
Yeah, the descriptive thing has to be quantified. So you can describe
Yeah, yeah.
something, you can quantify. I'll give you another example, a very
No,
practical.
I understand, Ashok. I get your point that it makes it measurable and quantifiable and
Yes,
easier to share, easier to document,
yes,
and
yes, yes.
easier to even change or modify your decisions.
Yeah. And we are
Thank
going
you.
beyond what is visible to us.
That is what I was interested in knowing. So maybe if you have serial data for past 2 to 3 years depicting the or documenting the RNFL loss of the nerve fibers in glaucoma, then you may be able to predict that this will last for another 5 years, 10 years at the
Yeah, but
same rate.
that's exactly where the problem comes, because RNFL is taken by segmentation.
Yeah.
So now segmentation is not accurate. One pixel this way, that way, your measurements are gone. So can you rely on them? No, you can't. So segmentation is not the answer, unless or until you have very high resolution OCTs.
Yes.
I would like to
That is.
add. I would like to add that some groups they have done all this. So there are some groups who have predicted the expected visual acuity from the OCT scan. So just the OCT scan, I suppose they just use segmentation and maybe deep learning. They were able to predict that this particular OCT patient will have this much visual acuity. And some other groups they have used visual fields. They used 35,000 visual fields database to predict the future visual fields of a new patient. You give the patient's visual field and IOP and the IOP target. So they will
Yeah.
say that at this particular IOP target, this is going to be your visual field for the next 1 year, 2 year, 3 year, 4, 5 years. So it was able to predict the future. So, and also Google back in 2018, they were able to predict whether the retina is of a male or female patient. I haven't found any retina specialist who is able to do that. Is this retina male or female? I don't know. It's able to predict with around 95% accuracy. Age of the
In fact,
patient, yes.
Don, I was
Predict
in
death.
fact, it
Don,
is
I was
now.
trying to ask the same thing in the chat box, that
Right.
making it segmented and giving a score is a little advanced digital imaging and giving it a score. If you bring analytics into this AI, then I'm sure you'll be able to do a preventive, like this particular person is going to get some kind of an macular damage in next 2 or 3 years. Are you able to
Yes.
predict that kind of an analytics by
No,
basis
if
of the scores?
There have been groups who have done that. Yes. They have been able to predict the future.
So that's exactly where the pattern comes in. A thickness of retina will not predict the vision well. May have the same thickness, but the pattern may be different. The loss of cells may be so much that the vision doesn't correlate. That's what is happening in macular edema also. I mean, people have increased thickness and all, and some fluid, but still the vision is not correlating with that. Either they have good vision or they have poor vision than what is expected. So the pattern becomes important. Segmentation is not the only answer for OCT, but a method which does not require segmentation, like the deep radiomics, which I showed, that becomes much more important, because segmentation restricts the analysis to this segmented area, to only one area. That becomes difficult because what you see is what you are segmenting, but the disease is beyond that. So you'll have to tell them and make the model which has learned to see the disease, the mild form, the very mild form, the severe form. So it takes into everything. It takes everything into
things.
account. So that is what is important.
Thank you.
And to those who are not
Miss,
familiar with OCTs, the OCT scans which Sir showed, they are just one slice out of several thousands of slices.
yes.
Yeah, we
So,
have a volume scan. You're right. I mean, this is, I've not shown all the details. There are a lot of things which are there with the regulatory bodies and all that, it's patent pending. But then we have volumes of scans. Like there's one data set that we have where there are 49 scans. There are say 61 scans. And then there was one with 100 scans in one volume. So you can get everything. That's why I said that you are taking the thickness of the central 1 millimeter zone. When you get all the volumes and you find that the area much above the fovea is the one where the macular edema is maximum. So you're not including that area at all. You have no way of getting the thickness of that area.
I'd like to bring in Dr. Ilango Setu. He would like to share something. Over to you, Ilango.
Ma'am, can I share the screen?
Yeah.
Sorry.
While Ilango gets his screen ready, there it comes. Yeah.
Okay. So, as a transplant surgeon, I did not have to deal much with images. First of all, I would tell that this was a wonderful lecture. I enjoyed every bit of it. Even though I'm not an ophthalmologist, I could see all the images. As a transplant surgeon, my challenges were different actually. We had a lot of processes to run in each patient, and what we tried to do is I had to be available for each and every small decision. So what we tried was convert all what I had learned to simple Python protocols. That was how I started getting inside AI when I started during the COVID phase. So this I'm sharing some of the things. So even though I'm a transplant surgeon, taking decisions for fatty liver is quite commonly asked by the patients. So what we did is nowadays UpToDate has huge amount of data to read about a particular subject and learn to do sufficiently good at it. That becomes very difficult. So what we try to do is break down UpToDate things into algorithms and then simplify the algorithms so that they can make a decision and help us treat patients in an error-free manner. I mean, things that we are not masters of. So I can focus only on the surgical aspects. So this one was an atherosclerotic cardiovascular risk calculator and statin decision in fatty liver patients. The one below, I hope my screen is visible.
Yes, sir. Visible.
Yeah. The second one is a NAFL-NASH decision-making principle. Okay, just for an example, I'll show you. I'm just putting up some numbers. So it automatically generates whether the treatment is required or not. And suppose I say a patient is obese, he has got type 2 diabetes, and then it helps us decide the treatment. Okay, this is non-alcoholic fatty liver disease, so you don't need any treatment. But if you say NASH, then it helps you decide all the things, okay? And you can generate a prescription with everything. For the obesity, you need semaglutide, you need empagliflozin or dapagliflozin, pioglitazone, vitamin E, everything. So it allows you to generate and think through the hepatologist. These are actually guidelines taken out from UpToDate. So algorithm writing, what I learned was just focus on the algorithm writing. That is the most difficult part now, that we have an information overload in almost every field. And this information overload takes a lot of time to process and actually convert into clinically meaningful things. I'll also show one more thing. This is for pediatric hepatoblastoma. Pediatric hepatoblastoma is a very rare condition. Even a liver transplant surgeon with pediatric interest will see them only once in a year. So there is a lot of information that gets into your gray zone. You will not remember them very clearly. You have to reread everything. So when I trained there, I had to write the CHIC HS risk classifier. This one is very, very simple. I hope I'm not boring. So this has exactly the algorithm, and it will help you generate the risk score very well. So it says it's high risk. So very quickly you can decide the high risk. The algorithm is also given here. And at the best time, we also learned how to do the Cycle protocol just based on 2 inputs, so that error-free chemotherapy can be given even in situations where you can have very little experience, like giving a complex chemotherapy agent you can get the right additive dose. So these are very, very easy to generate. What I have learned is, rather than focusing all our time on image-based AI learning, there is a large data set based on numbers within the medical field, which can actually be organized. We still we have lots of MHCs being done in our country, and the processing time is actually very, very high. Most of them wait for 1 day to get a report, whereas all those data points can be completely converted into an AI-based algorithm, which can give you instantly generated recommendations based on standard recommendations. So I started doing like this, and I was able to do something which is very useful for me in transplantation. And the best thing is that your mind also learns the protocol very well, and you are able to treat better and better. It's almost like a pseudo experience working on these algorithms. So this is just what I wanted to share. The the um, the key ability to work in artificial intelligence is to think in algorithms. And I found that once you write a good algorithm, it is easier to transfer the algorithm to a software as well as an entire training ladder, especially with regard to error prevention. This is one of the key problems in medicine we are facing. And yeah, I think that those are the 2 points which I want to make. The error reduction in clinical medicine, as well as the ability to teach the next generation, even to the level of the physician assistants, to make it very simple. So those can be very, very helpful. And incorporating this into electronic medical records will make our work stress-free. The more and more we work in medicine, we become intensely focused on one particular field. We are not able to gather information and for the particular patient. So for example, my patient has got a high cholesterol level, QTC prolongation, all those things, I have to consult a cardiologist. But if a system allows me to gauge the severity of the condition or give some basic treatment, we will all be able to manage our time at the bedside in a much better manner. Thank you. Thank you, sir. It was a very wonderful lecture. I enjoyed every bit of it.
Thank you. And just 2 comments on this. One is that what you need along with this is the explainability. What did the model actually look into and why it gave the decision? So that's very important. Then the trust comes only then the clinicians would use. So just an algorithm telling you high risk, but then, yes, what are the features? Why did it tell it's a high risk? That part is quite important. So that is what is really required.
The chick hatches has been used for quite some time. So I just used their algorithm and converted it into a Python program and then into a HTML code. The decision making and the algorithm was written by me looking at those diagrams. It's very much I have given the algorithm just below so that they can verify.
Okay.
So multiple times I have to verify, and I get other people to do it for me so that they can find out the errors. So each algorithm it takes a bit of time. You have to check everything so that every aspect of the algorithm works. You're right, sir.
That's the training part and other things. But no, when a person is using it, he also wants to see what features it uses. It has to tell you whether you take the sharp values, you take anything, you have to come out with that. So I think that thing is also important. The second thing that you mentioned was that the numbers, there's so many numbers there. Images are also numbers. I mean, don't think that images are not numbers. In fact, with your numbers, I could concatenate the image numbers also and have a model which is a multimodal model. It's so easy to do that. And that's exactly how we are going on to, that's exactly what is happening in future.
So
And Dr. Ilango, ophthalmologists and radiologists, they speak in pictures. That is that is why you're seeing a lot of images. Ophthalmologists and radiologists, everything they say is pictures, images.
So what I have learned is every one of us has a focused interest. For me, there's a lot of things on CT scan images, but I think if you get a good Doppler ultrasound to assess the flow pattern, everything, those things are helpful for me. So I'm also working on that in the background. But for me, the large picture is about numbers. To answer Dr. Ashok's question, I always give the underlying thought process in the algorithm of the algorithm for the decision making at the end of the output, so that the clinician can learn very well. That is how I also keep a check on errors inside the protocols.
Thanks for sharing, Ilango. Ravi, you had your hand up for a while. You wanted to say something? Meanwhile, Ashok, if you could look at the Prem's question, I'm sure parts of it you've already answered, but still, since it's there in the chat box, if you could think about that by the time Ravi finishes saying what he wants.
The only constraint is that I have a meeting at 10.
Yeah.
But it's just another 4 minutes after.
Okay, I'll be really fast. So thank you, Ashok, for giving not only a fabulous talk but ideas for retirement. But more importantly, what I wanted to ask you is for all your AI based modeling, you're going to need data sets, right? So who's curating these data sets?
The data sets are curated, which are available publicly also. And then I am doing it myself because that's what I learned. I mean, the whole thing that was taught to me. So for me, it was very easy. I didn't have to go to the computer science people to do something for this. I mean, I could do everything myself, and everything, even the user interface was developed by me. I use Streamlit for it. And so it's end-to-end complete. Though I am working with the computer science department also for certain other projects. I've got a PhD student under me for all that. So those things are there. But then, a lot, if the doctor learns himself or herself, that itself helps, and that's how one should really proceed. So everything, and it's the data processing or pre-processing is something which is very important. And that's a very good point that you've brought out,
Yeah, I mean, because it's not possible or feasible for everybody, especially if the data sets are large, it's going to be really hard, right? So for example, I'm thinking of those fundus photographs at Minnesota. I mean, can you imagine curating those? I mean, they have so many digital images, and just to go through them and say which ones should be used to train models, it's going to take forever. So I mean,
No.
obviously,
Algorithms can be made. I mean, I used 135,000 images from OCT scans, and that's how I made the model, the basic model.
no,
So
but those
it can be done.
135 scans, how do you know that they are the right scans to use?
He
I
said
mean, which molecules do?
135,000.
Yeah, that's what, no,
135,000.
yeah, that's what I'm saying. But out of those 135,000, how do you determine which ones are of good quality, which ones are not of good quality?
Yeah.
How do you do that? How do you train your model to know
Yeah.
this is a not evaluable
Humans.
scan versus this is a poor scan but still can be read?
No, if there is a
Humans. We
gross
use
error, that
humans.
of course is removed. The gross ones, they're of course removed with pre-processing itself. There are methods, histograms, and so many things are there, which you can easily single out or filter out certain images. Plus, you do want a little variation in the data set also. You want some images which are less illuminated also, so that the model is able to generalize well later. All those factors are there.
Okay, thank you.
We are going to be really out of time. There have been some questions about recordings of previous sessions. We'll get you all the details soon. Soon we plan to launch our website, and it will have various links for the talks and even the question answers. And so just give us some more time. As of now, there is a playlist of Marvelous Medicine episodes which I will share from the next time. I'll keep it ready and share, because I'm recording, I cannot minimize my screen. So we are almost out of time. So thank you, Ashok, John, and Sam. Ashok, any your closing comments, please?
No, thank you. It was just an excellent time that I had. Enjoyed the talk. There were good questions, nice interaction with people. And I hope I'm able to inspire, especially the ones of nearing my age, so that they could think about AI as their retirement planning. It's a very nice line to be into. Thank you so much.
Thank you. So we'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.
Right.